Hey, good morning, everyone. I'm Madonna. I'm one of the new PGY2s. Welcome to the new interns. I'm going to continue on with our pulmonary topic review. Should be a continuation of our small group questions that we had. I hope those questions were helpful. So we're going to cover the chapters about tuberculosis, pneumothorax, asthma, and COPD. And again, this is just kind of a basic overview. I really encourage everyone to read about these topics kind of on your own time as well. All right, so let's get started. So you are a eager resident and a patient comes in with dyspnea and you use your ultrasound, and this is what you see with M mode. How do you think this patient initially presented? Anyone can volunteer an answer. B? Yeah, okay, good job. So the correct answer is B. So the same picture on the previous slide is the one on the right. It's the barcode sign, and it's basically an absence of lung sliding. So normally what you want to see is the picture on the left, which is called the seashore sign, where you see visceral and parietal pleura are kind of sliding against each other, and it creates the seashore sign. I also have a video. So you can see in the video, starting at the top of the screen, you have the skin, the subcutaneous tissue, muscles, the ribs, and then in between the ribs below the intercostal muscle is the pleural line. And normally the pleural line should kind of be like shimmering, and that shows lung sliding. But here in this image, or in this video, you can see there's no lung sliding. And the sensitivity of these findings is 90%, and specificity is 98% for pneumothorax. Just to go over the other answer choices. So choice A was progressive dyspnea on exertion, bilateral lower extremity swelling that you would potentially see in CHF, and some findings on ultrasound. You could see B lines, you could see poor EF. Choice C was acute wheezing, dyspnea, which is asthma. You may not really find anything on ultrasound. Choice D, fever, chills, productive cough, that's pneumonia. You could see subpleural consolidations. You may see parapneumonic effusions. And choice E, pleuritic chest pain after a flight from Europe, that's a PE. If it's small enough, you may not see anything on ultrasound. If it's large enough, you may see signs of right heart strain. Okay, question 2. What's the underlying process seen in the supine chest x-ray in a patient that cannot complain of anything? Any guesses? D. Yeah, good. So the answer is D. So this is the deep sulcus sign, which you can see in a pneumothorax, and it's specifically on a supine chest x-ray, because when the patient is supine, the air is going to rise to the anterior chest and the lateral chest. So the costophrenic angle appears deeper on the affected side. This is a good example of a patient who may be intubated, or maybe they experience some trauma and they're obtunded for whatever reason. They can't complain of any kind of pleuritic chest pain. You might see this on the chest x-ray. It's something to think about. The other answer choices we had, irreversible bronchoconstriction, loss of elastic recoil, that's emphysema. You may see hyperinflated lungs, flattened diaphragms. Choice B was reversible bronchoconstriction, mucus production, that's an asthma. You may see a normal x-ray if there's no complications with asthma. Choice C, reduced EF, decreased forward cardiac output, that's CHF. You could see curly B lines, cardiomegaly, and potentially pleural effusions. And choice E was the acid-fast bacillus, that's TB, and we'll talk about the chest x-ray findings later. And then just to really go over pneumothoraces. So the first one is the supine chest x-ray, the second one being the upright chest x-ray, where the air is going to rise up more towards the apices, and you can clearly see the border of the lung. It's also something to think about when you're ultrasounding these patients looking for pneumothorax, is when they're sitting upright, you want to focus more on the apices where the air is going to be. And if they're supine, you want to focus more on the anterior chest where the air might be. And then this picture you never want to see, because tension pneumothorax is a clinical diagnosis. But you can see the whole mediastinum is shifted to the opposite side. Okay. Oops. Sorry. Next question. So back to that patient that we saw the barcode sign on. You finally get them on the monitor. Their heart rate's 135, their pressure is 80/55, their respiratory rate is 25, their saturation is 85% on room air. You think you want to do a needle decompression. Where is the best location for needle decompression? Little controversy. So the answer is actually E. There are two optimal locations. The first being the second intercostal space midclavicular line, and the second being the fourth or fifth intercostal space anterior axillary line. Recent studies actually show that the fourth or fifth intercostal space anterior axillary line has a slightly better success rate, and that's because the distance from the chest wall to the pleural cavity is minimized in that location. There are actually studies done in the US of the mean chest wall thickness, and it's about 4.5 centimeters. So it's recommended that you use a needle or an angiocath with a length of at least 5 centimeters to be able to get into the pleural cavity. Additionally, you don't want to go more medial than the midclavicular line if you choose that approach, because you risk injuring the mediastinal vessels. And when you're inserting the needle, you always want to go just superior to the rib to avoid the neurovascular bundles that are inferiorly located to the ribs. So you insert your needle with a syringe attached, and you keep inserting until you start to get air back. Then you can remove the needle and you can leave the angiocath in. This is only a temporary measure. It's only a temporizing measure because it converts the tension pneumo to an open pneumothorax, but you still need a chest tube to be placed. Additionally, if the patient's hemodynamics do not improve with needle decompression, you should consider other causes of shock, such as hemorrhagic shock or obstructive shock from tamponade. Additionally, it could be that the needle is not long enough to penetrate the pleural cavity, or the catheter may be kinked. Okay. Next question. You treat a patient for asthma. You decide to give 16 milligrams of Dex-PO. Which of the following doses of steroids is this equivalent to? And there are two correct answers.
B and C.
Good choices. It's actually A and E. So I just wanted to include this question to really emphasize that not all steroids are the same. There's actually many conversion charts, and there's an MD calc equation as well. But prednisone is much more potent than dexamethasone. And I think even for myself, oftentimes I just reflexively give 16 milligrams of dex in adult asthmatics. But it's always good to think about that's actually equivalent to 100 milligrams of prednisone, which seems like a really big dose. And that's equivalent to 85 milligrams of Solumedrol, which when we think about it, we usually give 125 for patients with COPD. There's many studies about steroids in asthma, specifically comparing the routes of administration, either IV or PO. Studies show there's really no difference between giving steroids either IV or PO in asthma exacerbations in terms of like effects on pulmonary function. However, it is important that you give steroids within the first hour because that's what reduces admission rates. There's also many studies done in the pediatric population in terms of giving dexamethasone versus prednisone, more specifically dexamethasone 0.6 mg per kg with a max of 16, either once in the ER or once and then again 24 hours later, versus prednisone 1 mg per kg per day with a max of 60 for 5 days. And again, there's no difference between relapse rates, hospitalization rates, or persistence of symptoms at 10 days. And additionally, dexamethasone may have better compliance for pediatric patients. They just have to take one more dose. And the side effect of vomiting is less with dexamethasone than with prednisone. There are smaller studies that actually looked at this in adults as well, with 12 milligrams of dex versus 5 days of 60 per day of prednisone in adults. And similar results were found. There's no difference between admission rates and relapse rates. Okay. You have a patient with severe asthma exacerbation, fails BiPAP, and is intubated. You want to avoid barotrauma, breath stacking, and provide appropriate timing for ventilation to occur. What vent settings would you want to put this patient on? Yeah, good. So you want to put them on the settings in choice A. So I just wanted to include this question to talk about the risks associated with intubation and ventilation of asthmatic patients, more specifically about barotrauma, breath stacking, pneumothorax, and then of course chronically there's risks of like ventilator-associated pneumonia and PE. But really I want to talk about auto-PEEP. So what is auto-PEEP and why do we care? So in asthma and in COPD, it's an obstructive lung process where the patients, when they breathe in, they can't fully exhale that breath prior to the next inhalation. So they're always going to have this positive pressure within the alveoli. And you can see on the chart, so normally when you breathe in, pressure is going to go from high pressure to low pressure. So when you breathe in, you create this negative pressure inside the alveoli, and that drives air inside the alveoli. However, in asthmatic patients and COPD patients, they have this positive pressure because they can't fully exhale that breath. And that means they have to work even harder to get the air to drive into the alveoli. And additionally, that pressure is going to keep building up if you don't do something about it. And that is going to decrease venous return and can cause significant hypotension. So the goal of ventilation in asthmatics and choosing your correct vent settings is try to minimize this auto PEEP. And that's done in 3 different ways. So you can either decrease the inspiratory time, meaning you decrease the amount of you give the tidal volume faster so that the patient can spend more time in exhalation to breathe that air out. 2, you can reduce the tidal volume. So the less breath that you give, the less breath that they have to give out. But you have to carefully consider this because you don't want to decrease the tidal volume so much that it just matches their dead space volume, because in that case, there's not going to be any gas exchange. And then you can also decrease the respiratory rate to enhance the gas exchange. So vent settings for someone with asthma, you want to choose a low respiratory rate, such as 8 to 10 breaths per minute, a tidal volume starting between 6 to 8 cc's per kg of ideal body weight, low PEEP, anywhere between 0 to 5. You can keep the FiO2, you can titrate it just to keep the saturation above 90%. And the flow rate should be high, like 80 to 100 liters per minute. And this is the rate at which the tidal volume is given. Okay. Which of the following reduces mortality in COPD? I think I heard it. Yeah, C. So long-term oxygen therapy is one of the things that reduces mortality in COPD. The only other thing that reduces mortality is smoking cessation. Both of these are kind of hard to achieve in the ER. The goal of long-term oxygen therapy is to keep your resting oxygen saturation greater than 90% or your PaO2 greater than 60%. And then there's also guidelines on how to start someone on long-term oxygen therapy, and not something we really do in the ER, but it's also based on findings of like RV strain, polycythemia. Medications used in COPD exacerbations like beta agonists, antibiotics, anticholinergics, these do not change the progression of the disease. It treats exacerbations, it treats symptoms, but it doesn't affect the mortality of these patients. Antibiotics given in COPD exacerbation should cover the common respiratory pathogens like strep pneumo, H. flu, Varicella. And commonly we use azithromycin or doxycycline. However, you also want to consider Pseudomonas in patients who are recently admitted or have recently been on antibiotics or have had prior sputum cultures that grew Pseudomonas. Okay, next question. Which of the following findings on chest X-ray may be seen in tuberculosis? Yeah, good. So E, any of the above findings can be seen on chest X-ray. It really depends on the patient's immune status. Just to go over TB basics. So the risk of TB is highest in immigrants from high prevalent countries like India, Indonesia, China, being HIV positive, being homeless, history of alcohol abuse, illicit drug use, incarceration, or patients who are in nursing homes. So TB is an aerobic bacteria, and it gets aerosolized and we inhale the droplets. When it gets into the lungs, it creates a highly antigenic response. So the immune system wants to wall it off. So it creates a granuloma, and this contains the infection, but it also allows the bacteria to thrive and survive and grow. And again, this depends on the patient's immune status. If they have a good immune status, they're able to potentially wall off that infection. If they don't, the infection can spread to areas of really high oxygen content, like vertebral bodies, the renal cortices, the meninges, and it can potentially just remain there dormant for years, and that's the latent infection. As patients' immune systems decline, either their CD4 count is getting lower or they're on high-dose steroids for a long time, their body can no longer contain the infection, and it can spread either lymphatically or hematogenously and can reactivate. And the symptoms of reactivated TB are the common symptoms we think about: fever, night sweats, weight loss, hemoptysis. And then, of course, you can get your extrapulmonary manifestations as well. So some immunocompromised patients may actually have a normal chest X-ray because their body isn't creating that immune response that we expect. Primary infections, we usually think it could be any infiltrate in any area of the lung, calcified lymph nodes, or hilar lymphadenopathy. And our reactivation infections are when we classically see the cavitary lesions in the upper lobes. So this is an example of cavitary lesion. The next one being miliary TB, and this one being hilar lymphadenopathy. I think this just is a good example of how TB is so variable in terms of how it can look on an X-ray. Okay. 35-year-old female with suspected asthma has been treated with Duonex, Dex, Mag. She's on BiPAP. She's given Epi. She initially improved after the second dose of Epi. However, a few minutes later, she began to feel dyspneic, and she's now tachypneic. What would her ABG show at this point? Yeah, so it would show mixed metabolic acidosis and respiratory alkalosis. So all patients with asthma will have some component of underlying respiratory alkalosis because they're tachypnic, they're blowing off their CO2. But in this patient who received beta agonists and Epi, she's going to have a metabolic acidosis from a lactic acidosis because everything is kind of revving up. And a compensatory response to metabolic acidosis is to breathe off that CO2 and to breathe a little bit faster, and that also causes a respiratory alkalosis. So even though her pulmonary function is improving with all these bronchodilators and the Epi, her overall picture is going to look like she's getting worse because she's trying to compensate for the metabolic acidosis. And just something to remember, ABGs and BBGs in patients with asthma, looking at their PCO2, they should have a low PCO2 because they're breathing rapidly. If they have a normal or high PCO2, it could be a sign of impending respiratory failure. Okay. 65-year-old male with COPD presents with worsening dyspnea on exertion for 1 week. Which of the following suggests symptoms are related to uncomplicated COPD exacerbation? Good, yeah, so it's the D sign. So D sign is just indicative of right heart strain, which is either from chronic RV pressure overload or volume overload. Oftentimes we think about it with PE, but it's not specific for PE. It can also be seen in core pulmonal and pulmonary hypertension, both of which happen in COPD. EKG findings that you might see in this patient are signs of RV strain, such as ST depressions, T wave inversions, and leads that surround the RV, like leads V1 to V3, 2-3 AVF. They may have a dominant R wave in V1, and they may have P pulmonal on EKG, which is a peaked P wave, which is indicative of right atrial enlargement. I just want to touch briefly on pulmonary hypertension. I think it's something that I personally often forget about in my differentials, but it's really important. There's many causes of pulmonary hypertension, but in COPD patients, the pathophysiology is chronic hypoxemic pulmonary vasoconstriction, which causes increased pulmonary vascular resistance, which puts a lot of pressure overload on the RV and causes RV dilation and impaired contractility. And eventually over time, the interventricular septum is going to bow into the LV, and that's what we see up here. Causing the D sign, and that impairs cardiac output and LV filling. Okay. And our last question, 55-year-old male with a history of COPD presents with worsening cough, shortness of breath. He's tachycardic to 115, he's a little hypertensive, he's tachypnic to 30, and he's saturating 90% on room air, he's afebrile. On exam, he has diffuse wheezing, his EKG shows sinus tach, his chest x-ray shows hyperinflated lung fields with no consolidation. His ultrasound shows a normal EF and no effusion. You start ordering your Duonex and salmeterol, but what do you want to do for the patient right now? Yeah, so you could start thinking about BiPAP. So the point of this question is to have you thinking, do you want to do supplemental oxygen? Do you want to do BiPAP, or do you want to do intubation? And this really depends on the clinical picture of the patient. So a better question would have included the mental status of the patient. So somebody who has a good mental status, who's awake and able to give you a better history, you can start with BiPAP and set up for intubation if you're expecting decompensation. Indications for intubation would be patients who have really severe respiratory distress and it looks like they're starting to tire out. If they don't have any mental status, so they're unable to protect their airway, they have very severe amount of copious secretions, a cardiopulmonary arrest, or if they're failing BiPAP. With BiPAP settings, you can start with 10/5 and you can up titrate as needed, frequently looking at the tidal volumes. And you want to keep the saturation between 88 to 92% to try to minimize VQ mismatch. And if the patient is really anxious on BiPAP, you can consider sedation like Precedex, which still helps, which doesn't impair the respiratory drive. ABGs can be helpful, but the PCO2 alone shouldn't tell you to intubate a patient or not. And in patients with COPD, their PCO2 is going to be chronically elevated. Yeah, these are my references. Any questions?